very much for joining us for this, what I think is an important and timely talk. Over the past weeks, we've seen the ways that coronavirus and the pandemic, and of course our social responses to it, have exacerbated a multitude of overlapping inequalities related to age, gender, class, ability, immigration status, race, and of course others. In Canada and beyond, we've had to bear witness to the various ways that neoliberal pressures on long-term care have worked to disadvantage not only the residents of long-term care, but also those who care for the old and the disabled, often those themselves who are precarious, underpaid, and work in unsafe conditions. As evidenced by the tragic situation in some long-term care homes across this country and beyond, we now know, but only in part, the impacts of structural inequalities on both long-term care residents and their workers. With this in mind, I want to welcome our panel who will help us think through what we hope are promising practices and next steps for long-term care in Canada.
Thanks for including me in your panel. I've been involved in research on long-term residential care for about 15 years now, and last month, as Kristi mentioned, we finished a decade-long study on promising practices in long-term residential care. And prior to that, I was involved in a large study on working conditions in Canadian nursing homes. And I want to share a few lessons today from these studies that are worth bearing in mind as we hopefully make some much needed improvements to the long-term residential care sector. And rather than talk about promising practices in the recent study, I want to actually start with my research on the seemingly unrelated topic of violence in nursing homes, because there's some very important parallels to be drawn to what we're seeing with COVID and the harms being inflicted on nursing home residents and staff, as well as the role that neoliberal policies have played in creating the conditions for this suffering. And specifically, I want to use this talk as an opportunity to introduce or reintroduce the concept of structural violence, which I think might be useful in connecting the history of neoliberal policymaking with the crisis of care in nursing homes and the suffering that's been exacerbated by COVID. So one of the first studies I was involved in back in the mid-2000s was an international comparative study of working conditions in nursing homes across Canada and Nordic Europe. And we wanted to learn from care workers firsthand across a number of Canadian provinces, and also in Denmark and Finland and Norway and Sweden, about their experience of working in nursing homes. And my research in particular focused on violence in Canadian nursing homes. And much of the research on violence up to that point had paid attention to violence between residents or the violence that residents experienced from staff. But what we found was that staff were also regularly experiencing violence from residents. In fact, that we found that for care aides, and those are the workers who provide the direct care to residents in nursing homes, violence was a constant and ongoing part of their job. The violence they experienced was physical, it was verbal, and it was sexual. Almost all Canadian care aides experienced some form of violence, and nearly half said that they experienced physical violence every day. Just to give you an inkling, let me read you the words of one aide who says, I've been punched in the face several times, I've been punched in the jaw several times, getting hit, having your wrists twisted, pulling and shoving you. That's a day-to-day thing. Violence is an everyday occurrence. So violence for Canadian workers was normalized. It occurred routinely and was treated often as part of their job. So we're interested in knowing whether this experience was unique to the Canadian context or if the situation was the same in Nordic Europe. And what we found was shocking. Did Nordic workers experience violence from residents? Yes, they did, but nowhere nearly as often as Canadian workers. Canadian long-term care workers were 7 times more likely to experience physical violence on a daily basis than their Nordic counterparts. 7 times. To put it another way, in Canada, 43% of care aides experience violence every day. The average in Nordic Europe was 6%. And Canadian workers were understandably distressed and often injured as a result. So we wanted to explain this suffering, and we couldn't attribute it to differences in residents. There was no significant difference in the type of resident that people were caring for in Nordic Europe as opposed to Canada. But we did find key differences in staffing levels and in working short, in particular, working short staffed. Staffing levels were higher across Nordic Europe, and working short staff was much less common. Nordic long-term care workers also reported that they had greater autonomy on the job, greater communication and collaboration among colleagues. And all these are factors that not only help mitigate violence, but contribute to quality care. And there were also factors that Canadian care workers consistently pointed to when we asked them why the levels of violence were so high. The way they put it was they simply just didn't have the time to do the work the way they knew they should be doing it. They didn't have time to handle residents appropriately when they were agitated. They didn't have the time to put their training to work, to do what they knew to do in the context especially of residents' distress. And they didn't have time to provide basic bodily care in a respectful manner. This is intimate care. So rushing through this kind of work threatened residents, and that often led to violence. It wasn't rocket science, as one of the care aides we interviewed told us. The links are fairly straightforward, and as another one put it, getting residents ready for the day, bathing and feeding all of them, there's just not enough time. 45 minutes to get 12 residents ready for breakfast. How the hell do you think that's going to work? So, why talk about violence between residents on a panel dealing with neoliberalism and COVID and care in nursing homes? I bring this up because this study taught us some very important lessons for thinking about some of the challenges that we're facing in nursing homes and where and how to intervene. And that's that we cannot separate the conditions of work from the conditions of care in nursing homes. Or to put it another way, if we want to improve the quality of care, and that includes protecting residents and staff from infectious diseases, we need to make sure our solutions address structural factors, whether that's at the policy level or the organization level, or ideally both, because these set the conditions for the kind of care that's possible in nursing homes. And to make this point, in 2012, we introduced the concept of structural violence in a paper we published in Social Science and Medicine. And we suggested that it was important to think about the violence that staff experience, not as interpersonal violence, as it's typically thought of, but as a form of structural violence. And the point of naming structural violence is to draw attention to the policy factors that set up the conditions where this interpersonal violence would be likely to occur. The conditions for violence, in other words, were set up in advance by decisions that were made at a distance, decisions that I'm sure we're going to hear about today. And indeed, one of the main lessons we learned is that much of what's possible in nursing homes is often determined outside of care homes by policymakers, regulators, voters, activists, etc. They set the conditions for care. And I want to pick up on this concept of structural violence because it's highly relevant in the context of COVID and our discussions on neoliberalism. The concept emerged originally in the 60s in the field of peace studies, and then was popularized by a physician and a medical anthropologist by the name of Paul Farmer to explain the way in which risks for infectious diseases like TB and AIDS were structured by social forces such as poverty, racism, sexism, and colonialism. Working as a physician in a medical clinic in Haiti, Paul Farmer encountered men and women who were sick and dying from TB and AIDS. And it wasn't possible for him to account for the way these diseases affected certain people in the Haitian population without paying attention to structural considerations like poverty, like malnutrition, like overcrowded housing and lack of access to proper medical care and equipment, etc. When we speak of viral transmission in biomedical terms, we often lose sight of these structural causes of disease, suffering, and death. So he turned to the concept of structural violence from peace studies and incorporated it in a medical context to make visible the way in which these infectious diseases were not solely biological harms, and to make the point that the risk for infectious diseases had been structured in advance. In other words, the trajectories contagious diseases take among the population were determined in large part not by the vagaries of bacteria or viruses, but by human agency, by decisions frequently made from afar but with very localized effects. So structural violence is useful because it names the consequences of these decisions as a form of violence, because the suffering is avoidable. It's particularly useful in the context of infectious diseases to draw attention away from specific viruses to the way broader social forces like neoliberalism, marginalization, ageism, and sexism in the context of long-term care put certain people at risk in our society. Structural violence is a connecting concept. It helps us connect economic and social policies and decisions made in the past with local and present forms of suffering. And it may be useful today in our discussion about neoliberalism and the crisis of care, which is currently most remarkably making itself visible in nursing homes through deaths from COVID and risks to exposure. But what we're seeing today has had a very long history in politics. So I'll stop here and keep my remarks short and pass it on to the next speaker. Thank you.
Hi, everyone. Thanks so much for joining us tonight. As Kristi introduced me earlier, I'm an itinerant policy analyst and social historian, currently working at CUPE. Right now, I'm interested in public services and the welfare state, particularly healthcare, and how economic forces and modes of production shape our experiences of those services, and subsequently, how those services shape our lives. Although I'm currently working at CUPE, I do want to make it clear that I'm not speaking on behalf of the organization tonight. I'm here sort of reflecting on my own experience over the past several years, both in my paid work and in my just general goings on in the world. Well, I've been studying and thinking about care work and elder care since 2008, when I spent a year as a live-in assistant for people with developmental disabilities at L'Arche Cape Breton. My interest goes back much further than that. Speaking to my mother today, I'm named after my mother's grandmother, who every winter from the time she was 63, when she was widowed, until well into her 90s, left her home in the fishing village of Gabrouse on Cape Breton Island to live with my grandparents and their 6 children in Halifax. My mother shared a bedroom with her grandmother for 15 years while she was growing up. And my mom often jokes about how if I ever buy a house, it needs to have a granny suite so that she can come and live with me. So this presents me with an interesting position, because I can see very clearly that the expectations around care work, the way that care work is gendered, have changed dramatically between my generation and my mother's. So tonight I want to talk a little bit about where we're finding ourselves right now in terms of long-term care. I'm going to start with just a little bit of a sketch of the sector and the sort of economic structures that bound it. And then I'm going to move into some discussion about sort of the business logic that I have observed being at play in public services right now, specifically in long-term care, and to think about what we can learn about the system by looking at how that logic has sort of infiltrated public services. And then finish by thinking about how we might conceptualize of a long-term care system that not only provides care and dignity for people in the final years of their life, but does so in a way that emancipates us from bearing the burden of gendered labor in the way that we bear it right now. So, without further ado, the long-term care sector in Canada, as I understand it, has really grown over the course of the last 35 to 40 years, maybe more than that, since the late 70s, I suppose, in response to three things that I'd identify. First, the growth in the senior population, and not only in magnitude, but also in terms of what those trajectories look like on a go-forward basis. In Nova Scotia, where I'm from, where I live, we have one of the most intensely aging populations in the country. The second factor, the expansion of women's waged employment. So women, from the 1970s, late 60s, 70s onward, facing additional constraints at the expense of the freedom of entering the labor market, right? Not having as much time to put towards reproductive work in the household because they're out earning a wage. And the third factor that I think has contributed to the development of this sector is the collapse of mutual aid networks in communities where people who lived in communities for many, many years, where there wasn't a lot of migration, could rely on their neighbors to a greater extent than I think we can today. And certainly economic migration and gentrification have a lot to do with that story. So the very existence of the long-term care sector, the fact that it receives public funding, creates jobs, and ostensibly lifts part of the burden of elder care from women, I think creates the illusion that this particular form of domestic labor has been socialized. But I think we have to be really careful about considering this project kind of finished in terms of socializing domestic labor or reproductive labor. Canada's failure to bring elder care under the umbrella of the Canada Health Act, I think, has left just enough space for a hugely profitable industry to grow there. The long-term care sector as it exists in Canada right now has been built by business, and I would argue is governed by business logic. The business logic that the long-term care sector is governed by, which I'm going to talk about, is epitomized, in my view, by lean management practices and just-in-time supply chain management. This logic really can't deliver either emancipation from gendered labor or the care and dignity that our elders deserve. So there's a longer and more detailed economic history here that I don't really have time to get into tonight, but I'm happy to share some links to helpful articles with folks so that they can dig into that if you're interested. But I want to start with sort of a prompt around what this idea of lean management is. I'm not sure if folks are familiar with this term, but I stumbled upon it a couple of years ago, and I noticed that the Nova Scotia government was hiring a number of lean management consultants in many different departments. And in order to be accepted for these positions, you had to have training in Lean Six Sigma business management processes and MBAs and this sort of thing. So lean management, the philosophy of lean management, is basically a process efficiency philosophy. It is about defining value and eliminating waste to create the same product with fewer costs. So waste, for a lean practitioner who's looking at a business space and trying to figure out how they can make it more efficient, could be things like excess inventory, supplies that don't need to be lying around but are. In a hospital, it might be empty beds or unused bed days. Could be staff who are not running from task to task, so any kind of idleness that might be identified. And also anything and everything, really, that could be considered surplus, unnecessary. So those are the things that lean practitioners identify as waste. The problem for public services is that waste, as identified by this philosophy, could also be called slack. So if you have a public service that you're operating, when you don't have slack, you lose capacity to withstand strain. And if you can't withstand strain, you will see breaks or ruptures at stress points. So I think that's sort of where we are now. And I'm going to give a couple more examples of how I see that happening in my work today and how I've seen that in operation over the past couple of years. So that slack that we're talking about in a long-term care facility is really what protects both the facility and the public in the event of a crisis. Eliminating the slack, I think, should really be understood as a transfer of risk from government and facilities onto residents, staff, and family members who really have no say or very little say in how that calculation is made. So the breaks and the ruptures caused by this strain and added pressure on stress points, these are not theoretical things. I think that people have been watching the news and hearing a lot about the horrific stuff that is coming out of facilities, especially in Quebec and Ontario. But we have plenty of horror stories here. I'm not sure if people would be, aware of the case of Kristi Dunnington, who is a Nova Scotia woman whose death in 2018 was such a break. Kristi was 40 years old. She had a cognitive delay, and she was a resident of Parkstone Enhanced Care in Clayton Park, which is a neighborhood of Halifax. It's a Shannex home. Kristi, over the course of several months, developed a bed sore that eventually, in the autopsy, it was not the autopsy, her sisters discovered was the size of a fist. Her skin had rotted through to her spine. Kristi passed away in March of 2018 at the Halifax Infirmary of sepsis from this bed sore. That is a break, right? That's a rupture caused by strain. Bed sores occur. I'm not sure how familiar folks are with what the risks are in long-term care homes, but bed sores generally occur when skin is moist and the individual in question is not moving around a lot. They're not getting relief from the pressure that their body is creating on their tissue. So for bed sores to develop, people have to be staying in the same position for hours and hours and hours at a time. And that is what happened to Kristi. Another break or rupture, more on a structural level, might be that I found a couple of years ago through a Freedom of Information request that 20% of the hospital bed days in Nova Scotia over the course of a 5-year period between 2013 and 2017 were being used or filled by people who had been medically discharged from the hospital, but who were waiting for a nursing home bed that was not available. That seems to be a pretty significant rupture in the system, again, caused by this lack of slack. So the most, I think, relevant example of this lack of slack right now in long-term care, and the one that has the most dire consequences, is the totally inadequate staffing ratio that facilities and workers and residents and family members are having to deal with. So in Nova Scotia, government only funds nursing homes to provide 2.45 hours of direct care per resident every day. And what we see is that that level was last changed almost 30 years ago, at a time when people living in long-term care had cars because they could still drive. So it's really, at this point, impossible to provide decent care to people who have demonstrated the level of frailty required to be admitted to a nursing home on this level of funding. It's not going to happen. So what this level of funding does is it puts one registered nurse on the floor to oversee the complex care of 58 residents, most of whom have at least 5 comorbid chronic diagnoses and 10 different medications that they're on average. With this level of funding, it's really not unusual at all for CCAs, that's continuing care assistants in Nova Scotia, to have maybe 6 or 7 minutes, as Albert was referring to help a resident get up, get cleaned up, and get dressed in the morning. So when you think about that kind of time crunch, that kind of stress, it is really inconceivable that you as a CCA would have a moment to sit with a resident and ask them how their day is going, or play a game of cards, or do something that would contribute to that individual's quality of life beyond simply keeping them alive. So on top of this existing difficulty with the staffing ratio, many long-term care workers in Nova Scotia are working short constantly. So that means that if you're a long-term care worker, you're a CCA on your unit, if someone calls in sick and you're supposed to be working with 3 other people that day, that sick call, your employer doesn't replace that person who called in sick. So you just make do with 3. In many cases, your employer doesn't replace the second sick call either, because there just aren't enough people to go around. There's so much, there's an exodus really from the industry, and employers cannot keep CCAs working in these conditions because no one wants to be put in these situations where they only have 6 or 7 minutes to provide the care that they know people deserve. We also have, so around working short, CUPE did a survey last year, found that 74% of staff were working short on a regular basis. Related to this, we also have huge levels of mandated overtime. So CCAs having average overtime shift lengths of 15.7 hours, sometimes people reporting overtime shifts of 38 hours. Like, what kind of care is someone who's been working for 30 hours capable of providing? So this really points to the fact that recruitment and retention in the sector is a known problem. It's very well documented. Despite the fact that it's a known problem and well documented, the Nova Scotia government decided a couple of years ago not to renew a bursary program that funded people who were looking to take a CCA course. There's, I guess, somebody looking at the process and trying to streamline it, trying to reduce waste, thought that this wasn't needed anymore in a sector that has the highest turnover rate of new employees, really, in all of healthcare. So all of this strain, all of these breakages, really re-familiarize care work. Women step into the gap when these breakages happen, when these ruptures happen. Children of elderly parents visiting see that it's impossible for care workers to spend quality time with their folks, and so they step in. They may see that their mom doesn't, she only gets a bath once a week. So maybe they come in and help her on their own time because the CCA is not allocated the hours to make that happen for that individual. I heard a very upsetting story a couple of years ago. I was working in the NDP caucus office. My colleague, Tammy Martin, who was then the MLA for Cape Breton Centre, had been contacted by a constituent. And this woman's mother had called her from her nursing home room, crying, saying that she needed to go to the washroom and that no one would come when she rang the bell. Now, the daughter lived 50 kilometers away from the nursing home. Imagine getting that call. What can you do? The next call came from her mother, and her mother had fallen. And again, she had pressed the buzzer, but no one was able to come to help. It's highly likely that when these things were happening, there are other emergencies going on at the same time that need to be attended to. There just is not the slack in the system to attend to more than one issue at once. It's just not there. So in these times that we're in right now, in COVID times, this need to step into the gap to make up what's missing has sort of folded in on itself. In the past few weeks, I've been getting more and more reports of long-term care workers having their employment terminated because they cannot find childcare. In Nova Scotia, essential service workers are not being provided with any additional funds to help them with childcare at this time, nor are centers open. Basically, the government has said, look, you know, you should be relying on your parents or your neighbors or your friends, and you can rely on small operators who, excuse me, have fewer than 5 children on site. But when you are a long-term care worker during a pandemic and your employer terminates your employment because you cannot find childcare, it really shows you the depth of what's going on in our system, and how much this project of socializing reproductive labor is very much unfinished. So just like to close with a question. What kind of long-term care system could deliver at least partial emancipation from the constraints of gendered labor and elder care, and at the same time provide care for people who are no longer self-sufficient? I think, you know, I get some answers to this question from Silvia Federici, who insists that what we need is the construction of collective forms of reproduction. So systems that are built by us rather than for us. I think her use of the word construction is really interesting here, especially in relation to how the Canadian long-term care system has evolved, because it's very much been a project done either by voluntary organizations, sort of charitable church-based organizations on the one hand, or taken up by the private sector as a new market on the other. So there are these two options that we have right now, and it seems to me that neither of them are working. That the profit motive has no place here on one hand, but at the same time, we need significant socialized collective funding to bring care levels up to a standard that is acceptable and that we'd be happy to have our loved ones live in. So I'm going to leave it there. I'd say that the key next step for me is thinking about how we bring care workers, families, and elders together with a set of common demands, and to think about what kinds of organizing we need to be conceiving of in order to make that happen. I think it's a new project, and I don't have enough time to get into that part of it tonight, but maybe we can chat about it in the Q&A. Thanks.
Okay, good evening, everyone. Thank you very much, and enjoyed the remarks of the other participants. I'm going to be talking about my research and the sort of neoliberal policies that have affected nursing homes in New Brunswick. And I've prepared a set of slides to show you. Okay, so this is just a little outline of what I plan to say. I'm just going to give a bit of an introduction, actually a rather long introduction. Then I'm going to be talking about the neoliberal policies that I think have affected nursing homes in New Brunswick, starting with the Sean Graham government in 2008, where he introduced procurement, and which led to privatization. In 2015, the Brian Gallant government introduced the budget, where he tried to change the assessment of seniors going into nursing homes so that their assets were included in the assessment. And he raised the cap on nursing home fees to residents from $113 to $175. So that was another neoliberal policy of cuts to social spending. And then this recent drama with Blaine Higgs and the unions, where he's insisting on wage restraint, and introduced this Bill 17, which is not allowing strikes and also limiting arbitration. And then I'm just going to finish up with the impact of all of this as I see it on seniors and workers. Okay, so my research in the last few years has been on the privatization of nursing homes in New Brunswick, and particularly the impact of this on seniors. And actually, my work was inspired by an Pat Armstrong article. And Pat Armstrong was the sort of head of the team that Albert Banerjee was on. And her article was on the privatization of long-term care in Ontario. So I tried to apply that analysis to the New Brunswick situation. First of all, I just want to define privatization in this context. When I say privatization of nursing homes, I'm meaning nursing homes being turned over to for-profit corporations as opposed to nonprofits. Some have argued with me that the community not-for-profits in New Brunswick are also private, but I'm not counting them as private. When I talk about privatization, I'm talking about the for-profit corporations. Okay, basically what I found when I looked at the New Brunswick situation was that since the 2008, the Sean Graham government, all of the new nursing homes that have been built in New Brunswick have been by one nonprofit corporation, and that is Shannex of Nova Scotia. You heard Mary Dan mention Shannex. Up until that time, up until 2008, all the nursing homes were community not-for-profit nursing homes. We have no public nursing homes in New Brunswick. At the present time, for example, we have 61 not licensed, not-for-profit, community-based nursing homes. And then we have 7 Shannex nursing homes, all built since 2008. And actually 2 more are coming on stream, one in Miramichi, a second one in Miramichi, one came recently, and this is the second one, and one in Fredericton off Cliff Street. I don't know if any of you have seen that. Here we have this privatization occurring in New Brunswick where Shannex is basically, all the new building has been by this one for-profit corporation. I wanted to see a little bit about the caregiving sector as a whole, though. What I'm talking about here is nursing homes, licensed nursing homes, but that's only one part of the caregiving sector as a whole. Caregiving sector is much larger than that. So for example, in New Brunswick, we have 68 licensed nursing homes, but we have over 400 special care homes. So nursing homes are a higher level of care, special care homes are the next level of care. We also have home support agencies and home support workers. We have community residences. We have memory homes, etc. So the whole sector, other than the nursing home sector, the Coalition for Pay Equity estimated that there are about 10,000 workers in this, other than the nursing home sector, in caregiving. So there are a lot of other workers. And I just want to say a little bit about those workers because I won't be talking about them, but just before we leave them, I would say that their situation is much worse than the workers in the nursing homes. Very, very few of them are unionized. And this is a group actually that the Coalition of Pay Equity has been working for. And they have worked, and they have brought about some increase in their wages through a government investment by lobbying for that. It also struck me that we haven't heard much about these other caregiving workers in New Brunswick during this COVID period. I don't know what's happening. But it strikes me that they would be eligible for this $4 pay raise if the government, if the New Brunswick government will go along with that program. So there's many, many workers who would be in that category, I would think. Okay, the last thing I want to say, just in terms of, by way of introduction, is what the rationale is for government policies. The government policies that we've seen, these neoliberal policies. So the government has been seeing, like, let's go back to 2008, a very big rise in the aging population, and they call it the gray tsunami. And they don't know how they're going to deal with this situation. They need more nursing home beds. but they feel that they can't afford more nursing home beds. So the path that they've taken, and this is both the Conservative and the Liberal governments, is to go the so-called efficiency route. They want to provide what's needed, but in a more efficient manner. And basically, efficiency for them is cost cutting. How can they provide the beds that are required, but at less cost? What Sean Graham did was that he basically invited in Shannex to begin with. He just invited Shannex in and to build 3 nursing homes in New Brunswick, one in Fredericton, one in St. John, one in Moncton. But there was a great cry about that. And the reason that he brought them in is he said that the private sector could provide them more cheaply than it could be provided by the not-for-profit sector. There was quite a hue and cry at this, so that this is not the way to, give up government contracts. And so this is when they brought in procurement. Now, procurement is when you ask potential builders and operators to bid on contracts for nursing home provision. And so when they did this and they started to follow this procurement process, giving the contracts to the lowest bidder. In every case, Shannex was the lowest bidder and they got the contracts. I just wanted to mention that this is actually the same thing that happened in Ontario. In Ontario in 1988, the Mike Harris government is when Harris brought in procurement for contracts for nursing homes, that the for-profit sector entered that industry. And similarly, reading a recent report of BC, and they say about 20 years when they brought in procurement policies, that then that is when the for-profit nursing homes started to enter into BC too. So they don't, in this procurement process, like not-for-profits can also bid on the contracts, it's just that they don't win them. So I'll just move on then to the neoliberal policies, the particular ones. Okay, so I'm saying that the outcome, so there are these kind of 3 types of neoliberal policies that I can see having been used in New Brunswick. And this first one was by Sean Graham, and this procurement and privatization, resulting privatization. I just wanted to say a little bit about the nature of the Shannex contracts. What Shannex gets with these contracts is a per diem, and that is the amount that the government pays for each resident. And it covers all of the nursing home expenses, except for the daily fee paid by residents. And in New Brunswick, that daily fee is $113. And that's true in all nursing homes, not just in the Shannex ones, but in all of the nursing homes. That is the cap, and that is what the residents pay, who are not subsidized by the government, with those with low incomes. Okay, and in addition, these licensed nursing homes are inspected by the government. So they're all inspected by the government, and the inspection reports are put up on the, are published, but they're kind of a yes/no thing. So they really don't give you a lot of information. It's a kind of a checklist. Do they do this? Do they do that? Do they do the other thing? With absolutely no details. Feeling frustrated with this information, and I think a number of other people, persuaded David Kuhn to apply under right to information for these contracts that Shannex was getting with the government. He did apply and he did get the contracts, but when they came back, all of the numbers were redacted. So there was really basically no information in the contracts other than, the words, but no amounts of money, no per diem, nothing about how the expenses were broken down or anything like that. So you couldn't compare costs with anything else. He even took when he got these redacted contracts, he even took the government to court to try to get the information, and Shannex brought in these fancy lawyers, and the Shannex won the case, and they still don't get the number. So there's no transparency. We don't know what, what Shannex spends the money on, or how they spend it, or whatever, and what money they get. All we know is the grand totals, because you can go to public accounts in the government, and I've done that. And in the period 2010 to 2019, Shannex has collected $162.1 million in contracts for their nursing homes. So I'll move on then to these other two neoliberal policies. And one was in 2015, Brian Gallant in his budget tried to save money by introducing into the nursing home system that when a senior was assessed to go into nursing home and having a financial assessment made, now it had been just on their net income, but he decided to also add assets in there when calculating their income. So it was income plus assets. And the other thing he did was he wanted to raise this cap, the most that a senior would be asked to pay as a resident, from $113 to $175. And $113, by the way, is already the highest in Canada, I think. So, anyway, this it's really atrocious. It was really an attack on middle-class seniors. For me, it's like asking middle-class people to pay for their own Medicare. Okay. I think nursing home care is basically a service that we should get like Medicare. And the $113 was just supposed to cover your room and board, but for the nursing care, that should be covered. So this was an attack on that. Anyway, there was a great hue and cry about it, and in the fall of that year, this was 2015, the fall of that year, Brian Gallant had to rescind the policy, so that was taken back. It was just not reasonable. So the third phase I can see where we could talk about neoliberal policy was a policy against unions and the wage restraint and the no strike legislation brought in by the Blaine Higgs government. Now, in the very excellent article that Susan O'Donnell wrote for New Brunswick Media, you can see that Blaine Higgs wasn't the only premier who really has treated the workers in the nursing home sector very badly. That Gallant didn't give them a good contract, and Graham froze their wages for 2 years, and Allward didn't have any successful negotiations with the nursing home workers. So it's really been a terrible situation. So in this latest, what Blaine Higgs is offering is he wanted to offer just 1% a year, which is not even the cost of living. And then he brought in this Bill 17, which doesn't allow strikes by nursing homes, and it doesn't, nursing home workers, and it doesn't allow any proper arbitration either, because the arbitration has to be based on the affordability in terms of what the government can afford. So really, it's been very unfair to workers. So those are the kind of three neoliberal policies that I would mention. Okay, well, what's been the impact on seniors and workers with Shannex, this for-profit corporation, which has come on the scene since 2008? Well, first of all, I'll talk about what I see as the impact on seniors, and I think the impact on seniors is in terms of the cost of nursing home care. Now, if you go into nursing home, as I said, that the maximum that you could be charged is $113, whether it's Shannex or it's one of the community not-for-profits. But the way that Shannex is different is that it's kind of complicated, but because Shannex has this campus of care, they have independent living, they have assisted living, and then they have the nursing home level. Okay, they have a kind of a special deal with the government that if you go into the independent living at Shannex, that you can be assured a place in the nursing home, their nursing home, when the time comes. So you won't be treated like the other people waiting for a nursing home, where you may have to wait 5 or 6 months and you may be sent to a nursing home wherever. So it's a competitive thing with them. They're trying to sell their independent living where they make all their money from, and they're using the nursing home as a competitive tool to accomplish that. So it ends up for a senior to take advantage of this, to have a smooth passage to a nursing home. They have to spend all that money in the independent living to start with. Now, in Ontario, they found the same thing, that there's this thing that waiting for the nursing home is the costly part for the seniors. About quality of care, now I haven't really been able to do any study of, it's very, very difficult to find out what's going on. It's so secret, everything's totally secret, just like the money numbers, but you know what's going on. The workers are sworn not to divulge anything about what's happening at work. So that's very difficult. So I can't really say that whether the quality of care in the Shannex is worse or better than the quality in the other not-for-profit. But from studies from elsewhere, for example, some of the work that Albert has been doing and Pat Armstrong have been doing, and some studies in the United States and BC studies have suggested that the quality of care in for-profit nursing homes is inferior to the quality of care in not-for-profit nursing homes. Okay, in terms of impact on workers, now Shannex, this situation is quite complicated as well. I would say that Shannex is very anti-union. So for example, in these recent negotiations, the bargaining is being done by, on the one hand, the Association of Nursing Homes, and on the other hand, the Council of Nursing Home Workers. Now, the Council of Nursing Home Workers is made up of 46 CUPE locals, and they make up the council, but there are 68 nursing homes. So there are, what, 64, 78, 14 nursing homes that are not in the council that are doing the bargaining. Okay, so these 46 CUPE locals are doing it, the council is doing it, doing the bargaining. And on the association side, although the association is officially at the table, in addition, there is a government lawyer at the table, and they make all of the financial decisions. So when you hear Higgs saying we can't afford this and we can't afford that, I mean, they are making all of the decisions about the wages of nursing home workers, okay, because they are basically funding them. So it's not a real bargaining. So they decide all the funding issues. Other things like the pensions and benefits and things are some of the other seniority and vacation and things like that. That would be decided by, between the association and the council. But any of the straight financial things are decided by the government. So Shannex, they have 7 nursing homes. None of those, only one of those nursing homes is in the council that is doing the bargaining. And this one nursing home that is in the council is just kind of, despite Shannex, what happened was when the new Miramichi 240-bed nursing home was built, it replaced 2 nursing homes that were already in Miramichi, and they were part of the council. And so CUPE made a very good move here, and they insisted to the government that in their procurement process, when they called for bids, the RFP, that they had to specify that whoever won the bid would have to take on the CUPE union that had, from the other 2 places. So the workers were going to be moved and the union was going to be moved. So that one Miramichi is the only one that is on the council that is doing the bargaining. Now Shannex has another nursing home that is unionized. That is the Thomas Hall in Fredericton. Now they're also a CUPE union, but a national CUPE union, and it's not, that union is not in the council and is not partaking in the bargaining. And I'm told that that union also has a inferior contract to the council one, that they don't have pensions and they have inferior benefits to the other one. So it's a kind of a inferior, it's also CUPE, but it's CUPE national. So it's a very complicated situation. So just to finish up then, what do I think about Shannex in the time of COVID-19? I mean, in terms of the question about our residents in Shannex nursing homes doing worse than the residents of other non-for-profit nursing homes in New Brunswick. Well, I don't think I can really say. I haven't, there haven't been any COVID cases in New Brunswick apart from one employee at in Concord Hall in St. John. There have been no residents with COVID as far as I know, and there certainly have been no deaths. So I really can't say. I was very shocked though, and very concerned that the situation in Nova Scotia, Northwood, the nursing home where there have been many deaths and a really a terrible situation, is a non-for-profit, and is one that I have heard highly recommended. It is a very good nursing home. So, and the Shannex has had some residents, but they have, I think 3 residents possibly have COVID in Nova Scotia. So, you know, I think, I don't know, I can't really say anything about Shannex under COVID versus others. Okay, I just, I'm going to stop there, but I just have a couple of things that you can ask me in questions if you want. I just wanted to tell you about. I do have an update on procurement, and that is that there has been another procurement process, and with this procurement process, they have brought in some other bidders. Now, I was going to tell you that I participated in this process and made a lot of noise and wrote letters to Brian Gillan and various things. And they do have some other names, but nothing has been done on it. So, and I don't know who these names are. One of them is Partners in Care, New Brunswick Partners in Care, based in Montreal. Now, I don't know who they are, and you know, one of my greatest fears is that, you know, Shannex is a not-for-profit corporation, but my greater fear is other for-profit corporations like the ones they have in Ontario or the ones they have in BC, the Ontario ones from the States and all the scandals that they've brought in, and the ones that they have in BC, some of them are just equity vehicles. For example, they're just people just use them for investing in or even for laundering money. So they're really, really, really terrible ones. And I just, with so much fear that some of these could be brought into New Brunswick with this procurement process. And I don't think we need any more Shannex. I think we have enough. Okay, and another thing is there's just recently been a study called A Billion Reasons to Care, a funding review of contracted long-term care in BC, where they compare the costs of for-profit and not-for-profit nursing homes. And it's quite interesting because they found that for-profit nursing homes cost the government more. And they also actually were making profits even out of their nursing home operations. So anyway, I gave the link for that particular study. It's a very interesting 2020 study that's been done. Okay, I'll stop there. Thank you.